My name is Dr. Heather Lau. I'm the director of the Lysosomal Storage Disorders Program at NYU Langone Health. I'm also the associate director of the Division of Neurogenetics. Today I'll be talking about COVID-19 pandemic and the impact on patients with Fabry disease. We'll start off with talking about the multisystemic manifestations of COVID-19, as well as the multisystemic manifestations of Fabry disease. And then we'll specifically talk about the impact of COVID-19 infection on patients with Fabry disease. Then we'll move on to talk about how COVID-19 is affecting access to care and therapy for Fabry disease. We'll also talk about what if you're exposed to COVID-19 and have Fabry disease. And finally, we'll talk a little bit about the ethical considerations of having severe complications of COVID-19, as well as the diagnosis of Fabry disease. So the typical symptoms of COVID-19 include fever, dry cough, and fatigue in the majority of patients. However, there are other manifestations of the disease that you may or may not experience. This includes a productive cough, shortness of breath, aches and pains called myalgias or arthralgias, which are joint pain. Some patients manifest sore throat, headache, chills. There are also some gastrointestinal symptoms, including nausea, vomiting, and abdominal discomfort, and diarrhea. In certain cases, people might have red eyes or conjunctivitis develop. And there are interesting reports of people experiencing a sudden loss of smell or a sudden loss of the sense of taste that does return after recovery in most cases. These symptoms typically develop after exposure anywhere from 2 to 14 days. They're transmitted by droplet, we think, through cough and sneezing, as well as through contact when you take your hand and touch your face, your eyes, your mouth, or your nose. And so if you touch a surface that had been infected with the virus and then go ahead and touch it with your hands and not sanitize them and touch your face, you have now transmitted the disease. There are also reports of fecal oral transmission. The disease then can progress over the ensuing 2 to 3 weeks, and either you can have a mild course or a severe course. Some patients actually never develop any symptoms, and they're asymptomatic, yet they can spread the disease. In severe forms of COVID-19, patients can develop pneumonia, then progress onto a syndrome called Acute Respiratory Distress Syndrome, or ARDS. They can also develop cardiac manifestations such as myocarditis, as well as kidney dysfunction. So what is acute respiratory distress syndrome, or ARDS? This is typically a complication of pneumonia, which is an infection of the lung. And then some people might develop ARDS. And this is an inflammatory response in the lungs that leads to fluid buildup in the tiny elastic air sacs called alveoli. This fluid, if you can imagine then, prevents your lungs from filling up with air. And that means less oxygen reaching your bloodstream. This deprives your vital organs of oxygen, and they start to have dysfunction. The symptoms of ARDS vary in intensity and are most definitely exacerbated by underlying medical conditions, such as Fabry disease. You can have severe shortness of breath, characterized by inability to carry on a conversation without losing your breath, or simply walking across the room, you become fatigued and start to breathe fast. Others will develop low blood pressure. They might have labored and unusually rapid breathing. And in certain cases, you might become confused or feel extreme tiredness and fatigue. There are complications related to ARDS. You can go on to develop blood clots that put you at an increased risk of stroke. You can develop a collapsed lung called a pneumothorax, which is usually a sequela of the need for mechanical ventilation. This is where a machine will breathe for you, and sometimes we need high pressures in order to provide oxygen into your lungs and into your bloodstream, and that could lead to a puncture of your lungs. You can also develop secondary infections such as bacterial pneumonia and sepsis, and some patients, even if they recover, they might develop some scarring of their lung tissue called fibrosis. So let's turn to Fabry and review the multisystemic dysfunction that we see in Fabry. We can see a variety of symptoms, including fatigue, You can see these characteristic eye findings of the cornea verticillata. Some patients will have difficulties with sweat, and they have heat and cold intolerance and exercise intolerance. More often in the classical and the cardiac forms, there are cardiac complications, including arrhythmias, conduction abnormalities, left ventricular hypertrophy, valvular dysfunction, and some go on to have heart attacks, heart failure, or even sudden death. Other patients will develop renal complications leading to end-stage renal disease and requiring dialysis. There are also manifestations in the GI system, the gastrointestinal system, due to dysmotility. So they might have cramping, diarrhea, bloating, and nausea. There are also neurologic complications of Fabry, including peripheral neuropathy, manifested by these episodic painful crises in their hands and feet. Others suffer from chronic daily pain as well. You can also have an increased risk of early stroke or TIAs, as well as affecting your hearing and tinnitus. And finally, you might have some characteristic skin findings called angiokeratomas. Now, there are several types of Fabry disease, and so all those symptoms I've just described do not necessarily occur in every patient. The classical form is usually have an age of onset in childhood, and those patients will have the typical skin and peripheral neuropathy findings, as well as inability to sweat. And they go on to have renal involvement leading to progressive renal dysfunction. And if without treatment, can go on to end-stage renal disease requiring dialysis. And then they go on to have cardiac implications, including the left ventricular hypertrophy and ischemia. These patients usually have a very low residual enzyme activity. However, there are attenuated phenotypes that many physicians actually don't know about. These are the renal variant and the cardiac variant. In the renal variant, onset of the disease is after age 25 typically, and they don't manifest with the skin findings, the acroparesthesias or the painful crises or the sweating difficulties. Some do, some don't. But typically in the renal variant, they do develop progressive renal dysfunction leading to end-stage renal disease with less effect on the heart. Some might have mild cardiac dysfunction. And then there's the cardiac variant, which is also a later onset disease, typically after age 40. Again, we don't see angiokeratomas or acroparesthesias, sweating difficulties, or the corneal opacities. But they do develop left ventricular hypertrophy that can go on to cardiomyopathy, oftentimes requiring transplant if left untreated. But their kidney dysfunction is typically mild and may manifest simply as just protein in the urine. And this is important to highlight because not everybody with the diagnosis of Fabry will have severe disease manifestations. And furthermore, if treatment is started early in the disease course, these patients might actually be stabilized and not have progressive dysfunction in their heart and kidneys, which would be very important information for someone evaluating you for COVID-19 infection. Now, Fabry disease is an X-linked lysosomal storage disorder. And most times we think of the men being more severely affected, and women simply are just carriers. However, we know now that females can be just as affected as males. They can range in severity from asymptomatic to severe end-stage renal disease. And these variations in the clinical manifestations in females is attributed to the fact that we have two X's as a female. And one of those X's is always becoming inactivated in our body. And so we are a mosaic of our functioning X's and our non-functioning X's. So the disease varies within women, even within the same family. They may have classical features like classical Fabry in men, including the eye findings, the painful acroparesthesias, the skin findings, as well as the sweating difficulty, as well as chronic abdominal pain and diarrhea. Sometimes we'll see the onset of these symptoms a little bit later than men. And they may also develop significant cardiac and renal disease, as well as early stroke and TIAs. So it is important not to assume that a female with, who carries a Fabry mutation is simply an asymptomatic carrier. They may manifest disease later in life. So let's talk about specifically how COVID-19 manifestations interact or impact patients with Fabry disease. Now, we talked about the respiratory dysfunction that we see in COVID-19 that leads to a pneumonia and in some cases to acute respiratory distress syndrome. Typically, the pulmonary function in patients with Fabry disease is not affected, but because of the other comorbid conditions, such as the cardiac dysfunction and the renal dysfunction, it might lead to a higher risk of progression from pneumonia to ARDS. This is not clear, but we would err on the side of caution that patients would be considered at higher risk. We would still need to assess the patient with Fabry disease for comorbid conditions that are not necessarily related to Fabry, but are so prevalent in our population that we should screen for them, such as asthma, COPD or chronic obstructive pulmonary disease, and emphysema. These conditions will put you at a higher risk of complications of COVID-19. Obviously, there is a significant amount of patients with Fabry disease that have cardiac dysfunction. And in COVID-19 infection, we do see effects on the heart. Patients have been reported to develop myocarditis or inflammation of the myocardial muscle. They could have even sudden cardiac death has been described. We see prolongation of the QT interval, which is sometimes attributed to the experimental use of hydroxychloroquine for the treatment of COVID-19. So as you can see with Fabry disease, where there might be varying degrees of cardiac dysfunction, this would negatively interact with the COVID-19 infection, leading to a higher risk of severe outcomes. Hydroxychloroquine is contraindicated in patients with cardiac disease. And we're seeing hydroxychloroquine with potentially with other medications being used even early in the disease to try to prevent progression of COVID-19. It would be extremely important for the Fabry patient to discuss this with their treating provider, that there might be a negative interaction. We are also seeing some renal dysfunction in COVID-19 patients. It might be due to the fact that there's hypoxia due to poor oxygenation in the lungs, leading to end organ failure. We're not clear, but we do see acute kidney injury in COVID-19 complications. And this would obviously impact our Fabry patients that have baseline renal dysfunction. Some of our patients are quite stable with just some mild protein in the urine, but other patients have lowered renal function, and they even require dialysis. Some of our patients have also gone through renal transplant, and the medications that help to suppress the immune attack on that transplanted organ would lead to an increased risk of our patients suffering from COVID-19 complications because they're immunocompromised. So let's move on to the neurologic complications that we're seeing in COVID-19. These are reports that are being generated in real time. We're starting to see reports of seizures. It may not be directly related to COVID-19 infection in the brain, but possibly in response to hypoxia or electrolyte disturbances as we're trying to manage the patient. We are seeing increased risk of stroke due to a hypercoagulable state that develops in COVID-19. We're seeing ranges of encephalopathy due to hypoxia. We even have a case report of necrotizing encephalitis or a direct infection potentially, headaches, and peripheral nerve involvement, including Guillain-Barré syndrome and cranial neuropathies. So as you can see, in Fabry disease, our patients already have an increased risk of stroke at baseline. Some patients may have already had a stroke or a transient ischemic attack or a so-called small stroke. They may already be on antiplatelet therapy or anticoagulation to prevent future strokes. This would be all relevant history to communicate to the ER or ICU doctor who's evaluating you if you have COVID-19 disease. An interesting aspect is that our patients who suffer from the painful crises, those baseline acroparesthesias, as you can imagine, this is exacerbated or triggered generally by fever, physical and emotional stress, as well as changes in barometric pressure. There's so many different triggers for our patients with Fabry disease, and it can cause severe pain and suffering. So if you develop a severe course of COVID-19, or even in the initial stages, these acroparesthesias may be exacerbated and require further management. Again, ER doctors, ICU doctors, and other medical providers may not be familiar with this, with acroparesthesias. And our patients and families need to advocate to inform them that this may worsen during the course of the illness. When we develop fevers, we need to sweat to release the temperature, to decrease our temperature. And in our Fabry patients, especially the classical variants, the classical type of Fabry, we have inability to sweat. So we have hypohidrosis or anhidrosis. So we would definitely need to treat fevers, and this is exacerbated in Fabry disease. Our patients have exercise intolerance as a result as well. We hear descriptions in COVID-19 infections of overwhelming fatigue and lethargy, and that could compound your baseline exercise intolerance. I'd like to also comment that sometimes in Fabry disease, we see this white matter disease develop. And it's relatively asymptomatic, sometimes found incidentally on a brain MRI. It should not be confused for an acute demyelinating process such as ADEM. This would be relevant information to the treating physician who may not know about Fabry disease. And sometimes people assume that if there's a white matter disease, there might be impact on memory or cognition. And it's important that most of our Fabry patients are not suffering from any kind of actual memory or intellectual dysfunction, that this is almost just an incidental finding. It is serious, but we don't have exact correlation to symptoms or severity of Fabry disease. So if we do see confusion or what I said, encephalopathy occur in the setting of COVID-19 infection, other causes should be looked at and not assumed that it's attributed to the white matter changes that have probably been there for years. Finally, there's also gastrointestinal symptoms that we are seeing in COVID-19 infections. Some people develop some abdominal discomfort, nausea, vomiting, and diarrhea. And because Fabry disease in the classical form can lead to GI dysmotility problems, you can imagine that their baseline GI issues might be exacerbated by a COVID-19 infection. Interestingly, there's some reports on a dermatologic or skin findings associated with COVID-19, a red rash, an urticaria. They think it might be mediated by microembolic or thrombotic causes. So our Fabry patients that have angiokeratomas, that might be mistaken for a COVID-19 rash. And so we would just need to inform, again, the treating and evaluating physician that these are not new. They're not, they've been longstanding and not petechiae or indication of either a clotting or bleeding problem. In Fabry disease, one of the classic features of the eye are the cornea verticillata that we see. And it's interesting because hydroxychloroquine and amiodarone are two medications that can also cause cornea verticillata. And there are reports that use of these medications may actually, in Fabry disease, may actually affect vision. So this needs to be screened for. Oftentimes in Fabry disease, we see cranial nerve 8 involvement. Cranial nerve 8 handles both hearing and vestibular or balance. And so a lot of our patients have varying degrees of hearing impairment, some requiring cochlear implants. So this is not a direct connection with COVID-19, but as you can imagine, if you're in the ER being evaluated, this, the lack or the inability to hear instructions could be a barrier to healthcare for our patients. So doctors who are treating patients with Fabry need to verify that their communication is being heard, to verify that their information is being understood, to speak clearly, and to verify understanding in the patient, especially because we'll be wearing masks, and oftentimes our patients who are hard of hearing may rely on lip reading. We also need to empower our patient to ask for clarification. This is a very stressful time, especially if you're having complications of COVID-19 and are seen in the ER. It might be confusing, it might be loud, it might be stressful. So, and you might be alone because not everyone's allowed to bring a visitor in. So we need to make sure that the healthcare provider understands that you have some hearing impairment. In Fabry disease, we do see some autonomic dysfunction as well as vestibular dysfunction that might manifest as dizziness, vertigo, changes in heart rate. These are all exacerbated or could be exacerbated with COVID-19 infection. The liver and spleen, typically in Fabry disease, this particular lysosomal storage disorder, we don't see liver dysfunction. However, in COVID-19, we are seeing impact on the liver, leading to elevations of the enzymes, and those elevations are indicators of a worse outcome for COVID-19. And it could lead to abnormalities in the synthetic function of the liver, including leading to bleeding and clotting issues, which would further increase your risk of stroke or cardiac disease manifestations of COVID-19. So that would interact with your underlying cardiac function or your prior history of stroke due to Fabry. So as you can see, there are so many different manifestations of COVID-19, and there are so many manifestations of Fabry disease that vary in severity within the individual and within families. And it is important that we educate the doctor who's evaluating you for COVID-19 infection to the various manifestations of Fabry disease. So let's move on and talk about how this pandemic is impacting our ability to treat Fabry disease. In this country, we have intravenous enzyme replacement therapy that's FDA approved for all forms of Fabry disease. We also have a new oral agent, a chaperone therapy called migalastat or Galafold, which is approved to treat certain forms of Fabry disease. So for infusions, we can do them either at an infusion center or oftentimes in our own home. However, with the increasing knowledge that there's community spread of COVID-19, especially here in New York City, our patients are concerned about being exposed to COVID-19 by their nurse. And also the nursing agencies and the infusion centers are worried about patients coming into their center with symptoms suspicious for COVID. So several weeks ago, when this started to happen here in New York City, we started to put into place certain practices in our infusion centers and in our home care agencies. Typically, patients would be called before their appointment to screen for various suspicious symptoms of COVID-19. And then they would be re-evaluated at the time of their appointment or upon arrival of the nurse to the home. And if any of these symptoms were endorsed, or there was a positive exposure to a patient with COVID-19, to another family member or friend with COVID-19, they would recommend a 14-day quarantine and to monitor for signs and symptoms. And then before returning to infusions, to speak with a healthcare provider to ensure that it's completely recovered. This is to prevent the exposure to the healthcare worker, who then may go on to infuse other patients and could potentially spread the COVID-19 throughout the infusion center or across different homes if there's home infusions. Now, there is that concern about the nurse coming to you and spreading to the patient. And our patients have called us to ask about, what precautions should be in place. So we are seeing that staff and RNs are beginning to not only use gloves, which they always do to start an infusion, but they are being masked. Some of the nurses will use an N95 respirator to protect themselves, and then also to some degree protect yourself. But there have been shortages in PPE, which is personal protective equipment. But our agencies and infusion centers are ensuring that there is adequate PPE for their nurses. Healthcare workers have not been routinely tested because there's been a difficulty to access those COVID-19 tests. And I'm hopeful that we will be able to do this as the testing ramps up. But in the meantime, we were concerned about pre-symptomatic spread as well. So not just when you're having symptoms, we're realizing that you can be contagious up to 2 days before developing symptoms. So nurses are asked to be mindful of their exposures and to wear masks. They're also self-monitoring for symptoms, taking their temperatures, and reporting in when they have any signs or symptoms that are concerning. Patients sometimes ask, should I wear a mask? Should I wear gloves? To a degree, masks could protect you, but the best way to protect yourself is to not touch your face when you're interacting with others, because the transmission is from your hand that you've contacted the surface, and now you're touching your face. The spread through cough or sneeze or close contact is mitigated by 6 feet apart distance. So nurses are going in, they're masked, the patient's masked, they're starting their infusion, and then they separate so that they're sitting apart to reduce the exposure. The other question that had come forward was that whether these nurses are also working at hospitals that are dealing with COVID positive patients. And certain agencies and centers had decided to just use exclusive nurses. So they are exclusively infusing patients only, and they are not volunteering or working at the hospital. We are also concerned right now, as we're hitting the peak of infections in New York City, that we might have a shortage of nurses as they're deployed to help at the local hospitals, which is a noble and needed endeavor. So that was also a concern on the minds of my patients about whether they would have an infusion nurse that could come to their home. So that led to the discussion about whether or not to defer infusions due to this, the fact that patients are scared to be exposed in the centers or going out into the community, even traveling to the center and exposing themselves, or having a stranger come into their home who could be interacting with other patients that might be exposed, as well as this potential shortage. Ideally, infusions would continue during this pandemic. We're not certain how long this will go on for. It could go on for months. And we do not want progression of Fabry disease during this time, such as progression in their kidneys or in their heart. And that's why it's important to talk with the individual about what their risk is. We advise our patients to speak with their medical provider about their particular risk versus benefit of continuing the infusions versus deferring the infusions during the height of the epidemic. And this would be typically done by reviewing the recent labs, looking at the last cardiac reports, the renal reports if relevant, and then risk of infusion-associated reaction when you stop therapy. In Fabry disease, we do see some infusion reactions, and some of our patients are pre-medicated. And when we come off therapy for a period of time, we might activate our immune system again and lead to a higher risk of a infusion reaction. So all of these factors need to be considered before you decide whether or not it's in your best interest to defer the infusion. And if you do decide to defer your infusion, whether it's 1 or 2 or 3 or 4 or whatever the agreed upon time frame, it's important that you and your medical provider stay in touch to reassess your symptoms periodically to see if you have any signs of progression, whether worsening of your pain, worsening of fatigue, or other aspects of your disease. Now let's talk about the use of oral chaperone therapy. Migalastat or Galafold is used in only certain forms of Fabry disease that have mutations that are amenable, that can rescue the enzyme and deliver your enzyme to the lysosome. Migalastat, though, is excreted by the kidneys. So as you can imagine, if you become affected with COVID-19 and you have severe complications, we have to make sure that your kidney function is maintained. You could theoretically remain on Galafold while you're being treated for severe COVID-19 complications, but your doctor needs to understand that if there is progressive kidney dysfunction or decline, the dose may need to be adjusted. These decisions should be made in conjunction with your Fabry provider, as well as the treating physician who's helping you with your COVID-19 infection. So how do you prevent exposure to COVID-19? Well, as the disease begins to spread within your community, you want to limit contact with others. Do not congregate in large groups. And you may need to look to your local guidelines on the limits of the number of people you can congregate with. Here in New York City, because we're at the peak of infection, we're actually under a shelter-in-place order where only essential workers should be going to work. No social activities with anyone outside of your household. And you may only venture out for groceries, medical appointments, and exercise. So when you're outside in the community, we are recommended to wear a mask to prevent our spread to others, even when we're pre-symptomatic, to maintain at least 6 feet from other people on the sidewalk, or even when you're going into stores. The stores are limiting the number of people in the store. And while you're out, to try to avoid touching your face, your eyes, your nose, or your mouth, because that is a pretty significant factor in transmission. And if you're out and about in the community, to carry with you hand sanitizer and using it frequently, or upon arrival to your home or in the bathroom or wherever you may be, you can just use simple soap and water for 20 seconds to wash your hands. That will kill the virus. Those are important ways to protect yourself from getting exposed to COVID-19. If your community is not yet on lockdown or not requiring only essential workers to go to work, but the epidemic is spreading and you're considered in a high-risk category having Fabry disease, it might be prudent to speak with your employer or your school about remote learning or working. You might need to ask your Fabry provider for a letter to outline your increased risk of COVID complications. This may also be needed if you're deemed an essential worker, but the risk outweighs the benefit of continuing your job. So what happens if you are exposed to COVID? You should contact your primary care physician and your Fabry disease provider to discuss the exposure, the symptom onset, your current meds, and your current comorbidities and severity of disease. You should self-isolate immediately, at times even from others in the home, because there might be other vulnerable people in your home. You should self-monitor, which means looking for signs and symptoms of COVID-19 and taking your temperature twice daily, looking for a fever which is defined as greater than 100.4 degrees Fahrenheit. And as you're monitoring, you're looking for a progression of the symptoms, worsening of the disease. You should talk with your doctor about when do you go to the emergency room. Here in New York, it is not suggested to go to the emergency room if you have simply mild symptoms of a fever and cough. This is because the emergency rooms are overwhelmed with patients that are more severe. And also it might be an exposure if you in fact do not have COVID-19, but you simply have a cold or the flu. So most of our providers are interacting with patients through telemed visits, and they're advising when to go to the emergency room. It might be earlier for you with Fabry disease because of your underlying cardiac or renal dysfunction, because you could have a rapid decline. So in preparation, just in case your symptoms become severe, I do suggest that while you're at home, you create a to-go bag. And in that bag, you have your updated list of medications, you have an updated list of your medical conditions, your advanced directives, including your healthcare proxy, and a list of primary contacts. You may want to ask your Fabry doctor for a letter stating what is Fabry disease and how it's manifesting in you. Because when you arrive to the emergency room, you may not be able to go in with someone. Here in New York City, we have limited it to no visitors for adults and only 1 visitor for children. And because you might be frightened or short of breath, or you just might be stressed, you may not remember all your relevant medications and conditions, and you might not be able to adequately explain to your ER doctor how is Fabry affecting or potentially could impact your COVID-19 infection. So when do you seek medical attention? Obviously, you should talk to your doctor about more specific symptoms, but in general, what we're looking for are these emergency warning signs, such as trouble breathing. So that could be you're having a conversation and you're short of breath. You can't walk down the hallway in your apartment or home without feeling severe fatigue, or you start to breathe rapidly. These are all signs of trouble breathing. You might develop bluish tinge around your lips or face. That should suggest that you have impaired oxygenation. You might develop some pain in your chest or pressure. And other signs include confusion or lethargy. Those are all warning signs that are important to prompt you to go to the emergency room or call 911. This list is obviously not inclusive, and you can speak with your medical provider about your specific symptoms that suggest severe disease complications. So finally, let's talk a little bit about ethical considerations for patients with Fabry who develop the severe COVID-19 complications. This may not be affecting you in your community, but here in New York City, we had a shortage of resources, including initially with personal protective equipment, such as masks and gowns and gloves. But we also have shortage of equipment, including the much needed mechanical ventilators, as well as dialysis machines. So does the diagnosis of Fabry impact eligibility to access these limited resources? And it's in my opinion that a simple genetic or biochemical diagnosis should not automatically exclude a patient from much needed care, including mechanical ventilation. We should not discriminate just solely based on that diagnosis. Many of our patients are well maintained on therapy, especially if it started early. Or many of my patients who have more attenuated phenotypes or women are completely asymptomatic or pre-symptomatic. They will not be developing cardiac manifestations for years to come. So it's important that our patients are assessed as an individual, and their risk is stratified by their age, their current comorbidities, not the potential for future comorbidities, and the current function of each organ system, just as we do for everyone else that walks into the door. So if you become ill and you're concerned about hospitalization and complications from COVID-19, reach out to your Fabry expert provider immediately and talk with him or her about your particular risk and whether or not a letter stating your disease and what it is appropriate, as well as ensure that you have your Fabry expert's number. And you can always provide that to the ER doctor or the ICU doctor taking care of you. So thank you for taking the time today to listen and learn more about the impact of COVID-19 pandemic on our patients with Fabry disease.